Good afternoon and welcome. My name is Jessica Gates and I'm Senior Vice President of Marketing for Ipsos. And I'd like to thank you for taking the time to join our webinar where we're going to be examining the current view of the entire ecosystem of medical devices and diagnostics. So our session today is being led by experts from Ipsos's North America MedTech team. You see the team in front of you here. We have Jana Pattison, Meg Gavigan, and Dan Carlo. You can read more about our speakers, obviously, in the bios in front of you. So to orient you and just provide some guiding notes for today's agenda, our presentation is going to run for about 30 minutes, and then we're going to use the balance of our time together to address your questions live. So we do welcome and encourage you to submit questions as the session goes along. You simply use the questions function in the console in front of you, and it will submit a question privately to our team. We're going to address as many as we can get to within the time allowed, but if we don't get to your question, certainly we will follow up with you one-to-one afterwards via email. Also, should you have any technical issues, you can use the same chat function to reach out to our support team. Additionally, we encourage you to look in the handout section. We've loaded up some information on our global medtech capabilities, so would encourage you to take a look at that and download it. And also, I would like to mention that, of course, our session is being recorded, and we will be sending it to you via email in case you wish to revisit the material or perhaps share it with your colleagues, which, of course, we encourage you to do. And so now we're going to get started on our journey through the medtech ecosystem, where we're going to be looking at insights from our research across clinical labs, surgeons, hospital administrators, and payers. And so with that, actually, it's Dan who's going to get us kicked off speaking about clinical labs. Dan, over to you.
All right, well, thank you, Jessica, for that introduction. And thank you, everyone, for joining today. Today, I will walk through findings from our recent U.S. Clinical Lab Impact Study. This study features a total of 75 U.S. lab directors and managers in the clinical setting. These individuals are lab purchase decision makers and influencers with an average of 17 years experience in their current role and a significant percentage of their time dedicated to oversight and management of clinical testing services. Of the 75 respondents, 5 were in the commercial/reference lab setting, while the remaining were in the hospital-based central lab setting with 16 academic hospital labs, 46 community hospital labs, and 8 rural critical access hospital labs. The methodology here was a 25-minute survey with mostly closed-ended questions. And additionally, we conducted qualitative callbacks with some of these labs to get more color around the key topics. And throughout the slides, you will see some direct quotations stemming from those discussions. And finally, the results were fielded in the last week of April. And with that background, I will jump into the first discussion topic, which is the evolving COVID testing market. At the time of our survey, 56% of labs had already implemented COVID testing in-house, while an additional 36% plan to adopt within the next month, suggesting that by now over 90% of labs have implemented COVID testing in-house. The first wave of implementation was largely PCR-based, but a significant share of labs also report adoption of serological antibody testing. Alternative test methodologies such as isothermal amplification, NGS, and Sanger sequencing also experienced some uptake. Testing appears to be largely decentralized within healthcare systems, as 68% of respondents indicate they are not the only lab within their system that's performing COVID testing in-house. And the market also appears that it's here to stay, as 57% of respondents believe that COVID will be a seasonal infection as opposed to a single outbreak. Overall, labs are really trying to assess the various testing scenarios across their organization. This is ranging from testing of asymptomatic patients pre-surgery to screening of their employees. A key question here being what will be the demand moving forward and how will COVID testing strategies shift, and trying to understand what will be temporary and what will be permanent in this landscape. And for any manufacturer in the COVID test market, it's going to be imperative to carefully evaluate the evolving testing scenarios to understand what is the best fit for your platforms and tests. Now let's take a look more closely at COVID test kit adoption and value drivers. Largely, labs are pursuing a commercial kit-only approach, with a small share of the market pursuing a combination of commercial kits and lab-developed tests. The three greatest value drivers of commercial kit selection are that the necessary platform is already available in-house, the test is accurate, and the test has a quick turnaround time. Secondary value drivers were also test cost and throughput. Overall, as the quotation here at the bottom suggests, labs are leveraging multiple different platforms internally to optimize their testing strategies with all these various patient and employee testing scenarios. And for manufacturers, it's really going to be important here to align your COVID test value propositions with the current needs of the market, as well to monitor how these drivers evolve as the market evolves itself and matures over time. And with that, let's now transition to the overall impact of COVID on clinical labs. Expectedly, over 99% of labs have been impacted operationally in some way. Over 80% of labs reporting decreased clinical test volumes across departments, and this ranges from clinical chemistry to hematology, oncology, genetics, and genomics. And this is a finding which seems to align with findings from our HCP and surgeon surveillance studies on decreased patient volume across healthcare systems. Additionally, 68% of labs have experienced a reduction in force within their laboratory. And due to these ongoing challenges, a majority of respondents have significant financial concern for the labs. Overall, it does appear it's going to be a challenging time for clinical laboratories, and it is going to require some adaptation. And as this next slide shows, labs are adapting their test strategies in a number of ways right now to address these challenges. The most commonly adapted strategy that we saw in our survey is a reduction in the number of batches or runs per week for certain tests. Other strategies that are also taking hold include running more molecular-based tests and altering traditional in-house versus send-out patterns, as well as overall more automated testing and workflows. And from a manufacturer perspective, what these findings all point towards is that there is an opportunity for further automation and molecularization of the clinical lab setting, and value propositions related to reduced hands-on time, streamlined workflows, optimal throughput, cost effectiveness are likely to resonate more strongly given the acute awareness of these challenges for the lab stakeholders and the messages that these value propositions seek to address in the current environment. Now we're going to shift gears again and discuss the overall impact on lab purchase decision making. 72% of labs in our sample indicate there is a pause on capital equipment purchases, while interestingly only 19% report a pause on reagent rental-based agreements, suggesting a near-term shift to such agreements, as well as other contracting strategies that could perhaps reduce upfront costs and help alleviate current financial sensitivity for these provider organizations. Of the labs with such restrictions in place, 88% expect these restrictions to remain in place for at least 3 to 6 months, suggesting that these capital purchase challenges are likely to persist for an extended period of time. And overall, 73% of labs expect to make no additional capital purchases for the remainder of 2020, while 57% expect significant budget cuts in 2021. And from the callback discussions we've had with laboratories, these cuts are more likely to impact instrument purchases as opposed to testing and reagent budgets. From a manufacturer perspective, it's going to be critically important to monitor how these purchase trends evolve. With the labs facing an abundance of challenges, it's understandable that their perceived outlook is pessimistic. However, should recovery efforts accelerate and perhaps this outlook changes to a more optimistic view as opposed to what is showing right now. Further, future lab purchases are likely to involve more non-clinical stakeholders, with executive teams keeping a more closer focus on what's going on with purchases. And with all departments across the hospital setting facing purchase restrictions, once they're lifted, there will most certainly be some pent-up demand across those departments, yet finite dollars for the provider organization. And therefore, you're likely to see labs having to compete more with capital priorities across their respective organizations, which is going to make value-based purchase decision-making more important than ever. With that, we'll now transition to our final topic regarding diagnostic reps, virtual sales, and e-detailing. In-person interactions have ground to a halt over the past month or so, with 33% of labs entirely eliminating such visits, while another significant share are limiting in-person interactions to only necessary training and maintenance procedures. Most labs expect these restrictions to continue for at least 2 to 3 months. However, despite these challenges, labs do remain interested in learning about new products, In fact, we learned that 68% of respondents are interested in learning about any platforms and assays, not just COVID-related offerings at this time. Finally, beyond product-specific discussions, labs do see opportunities for manufacturers to continue to strengthen their customer engagement and build brand equity with interest in creative solutions and consultative services. And things are quickly transitioning to a virtual environment. 75% of our respondents have participated in a virtual sales call within the past 3 weeks. Unsurprisingly, 73% of those discussions were focused on COVID testing. The majority of the calls are considered at least moderately effective. And with our callback conversations, we've tried to get at the drivers of a perceived effective virtual call versus a less effective virtual call. And it really seems to come down to two components here. The first we'll call the basics, your virtual etiquette, such as hosting on a platform that works for the lab, double checking connections and no microphone or screen share issues. Second is the content itself. These presentations should be crisp, they should be salient, yet they should cover the necessary info for the lab to understand the product and the value. And in the quotation below, the respondent described this interaction they had as an extremely effective one. And they actually called it a boardroom ready presentation in their view and were impressed overall with the way the reps maneuvered in a virtual environment. And in total, labs are receptive to virtual calls and e-detailing. Digital communication, phone calls, video conferences are all perceived as preferred interactions with diagnostic reps, suggesting an opportunity to pivot towards these approaches in the future. One of the areas respondents see the greatest value for virtual interactions is in the introduction stage to any new platform, instrument, or assay. And one important thing to keep in mind with any of these interactions is that the duration should overall be fit to purpose. For a standard virtual sales call, no more than 30 minutes, 15 minutes, that's an acceptable time frame. However, if you're looking to have some sort of a virtual platform or assay demonstration, then respondents feel an allotment of 30 to 60 minutes is considered more acceptable. Overall, proper lab stakeholder communication in a virtual environment comes down to channel, content, and cadence, making sure you're reaching out and interacting via appropriate means, making sure your content is optimized and on point, and making sure you're engaging labs with the right frequency. That takes us through the top-line findings from our US Clinical Lab Impact Study. Hopefully these findings offer a nice pulse of the current market and where things stand on a variety of topics. For manufacturers, the key question is what's next, what's temporary in this space, and what's going to be permanent, and monitoring how the market will continue to evolve, as well as how to recover. It's going to be critically important here to continue to monitor the market to stay on top of trends, ensuring that your business is well informed and you can make decisions that put you in a position for success here. And that concludes our clinical lab discussion. So with that, I will now turn it over to Jana, who's going to walk us through findings from our recent surgeon surveillance study.
Thank you, Dan, and good afternoon, everyone. As part of our clinical surveillance of COVID-19, we also wanted to measure the impact to the surgical space. And so what we have done is conducted an online survey across 11 surgical specialties, which you can see here. And in total, we captured 530 interviews across those stakeholders between April 11th and April 21st of 2020. So today we'll be showing some of those findings in aggregate across the specialties. And for the purposes of this study, we have defined pre-COVID-19 as prior to the time of March 1st, 2020. So with that, let's first take a look at procedure volumes. Not surprisingly, we saw a pretty swift and significant impact to those procedures as a result of COVID-19. And as you can see, nearly 9 in 10 procedures that were scheduled between March and May of 2020 were postponed or canceled as a result. Looking forward to rescheduling, we saw that only about a third of our respondents had rescheduled those procedures for a new date, but among those, about 2/3 had scheduled out 1 to 2 months, while another third were waiting for another 3 to 6 months to schedule. One of the more important things to note here is that about 20% of the procedures are considered to be at risk altogether. That is, they're concerned that there may be leakage of those procedures. In follow-up conversations with our surgeons, they really had a lot of different theories as to why this might be, but two primary ones stuck out. The first being economic factors, and the second being health concerns. So considering that some patients may have lost a job or insurance coverage that no longer makes an elective procedure financially reachable, and also that patients may have a remaining fear factor and not feel comfortable coming in for an elective procedure in the midst of the pandemic. So looking at who really was driving these cancellations, we saw that half the time it was generally led by the hospital itself, a third of the time by the surgeon, and just 12% of the time by the patient at the time of this survey. This is an area that we're anxious to watch and see how it evolves. As elective surgeries are coming back online, will patients feel comfortable coming back in for those elective surgeries? And what requirements might they have to feel comfortable with moving forward? Another area that has seen change due to COVID is at least a temporary increase in the adoption of telemedicine. You can see that prior to COVID-19, telemedicine was used in very few patient interactions by surgeons, and now those numbers have increased to 39% of pre-surgical consults and 48% of post-surgical follow-ups. Interestingly, though, this group, more than other healthcare stakeholders that we've observed at this time, are less likely to really seem to be latching on to the technology. And you can see that in what we deemed a post-COVID-19 period, there's still a bit of leveling off here. While it's much higher than pre-COVID, about 20% of those patient interactions are predicted to use telemedicine, it's still a significant drop-off, and more so than we've seen across other healthcare stakeholders. Follow-up discussions with them really indicated a feeling that surgery is such a hands-on specialty. They're really used to having that face-to-face interaction with patients, and there's really a lack of comfort with trying to make decisions as to whether a patient is a suitable surgical candidate or whether or not a patient is healing well post-surgery and not having that face-to-face interaction. So there's a good deal of reluctance there. And again, this is an area that we are hoping to monitor in our Wave 2 work to see if, as they have increased their usage of this, if they may find increased applicability for the technology or increased comfort, or whether they still kind of intend to abandon it post-COVID. We also wanted to take a look administratively, and we could see great impacts there as well. Nearly 72% of our surgeons said that they had reassigned staff across departments, and nearly as many said they'd had at least a temporary furlough within their facilities. And what we wanted to call out here in green is that 68% of our surgeons noted a capital equipment purchase decision pause within their facility, and 51% had also paused those ongoing product evaluations. This is largely in line with the numbers we saw from our lab stakeholders. As to how far these pauses are expected, most of them were saying 3 to 6 months out or further. And in digging further, they really talked about that need to get through that backlog of procedures as they come back online, making sure that patients are taken care of first in order to have the time and attention to give to those conversations, as well as to resume the revenue flow necessary to actually pull through with some of those purchases. And so in reality, many of them were thinking that the end of Q3 or Q4 might be the most realistic for when those conversations would resume, pushing a lot of the decisions into 2021 and further. Half of our surgeons agreed that COVID-19 is going to have long-lasting implications for surgical volumes and for scheduling. So in addition to some of the things that we've talked about in terms of that patient comfort level, we also have different things going on depending upon the site of care, depending upon the geography, that are going to indicate how quickly those can come back and they can start to get up and running again. Still, only 1 in 5 agree that this is going to change how their practice works with med device companies going forward. This is kind of a constant theme that we saw with surgeons, more so than other specialties that we've been monitoring through COVID. This group seems more likely to feel like things are going to mostly go back to normal in a post-COVID period. And so we wanted to then take a look at what that means for our medical device reps, which we will look at now. On the left here, you can see that in midst of COVID-19, physicians were previously interacting in person with their med device reps about 14 times per month, and that number has dropped to just 3 times per month for those in-person interactions. And in fact, about a third of our surgeons say that their facilities have eliminated medical device rep visits altogether of any kind. Still, there's some important numbers that we wanted to share with you today. About 47% of our surgeons said they've been contacted by a medical device rep within the past 2 weeks for a virtual sales call. And more interestingly, once contacted, they were very likely to go through. So 89% of those who were contacted actually did go on to participate in a sales call. And 2/3 of these surgeons said the number of times they're being contacted is just about right. They did have some caveats around this, though. Our surgeons found that less than 15 minutes is acceptable for a virtual sales call. This is a lower amount of time that they're allowing than what we saw with our lab stakeholders. And they really want that discussion to be targeted. And if we look to the right, there's a ways to go here in terms of efficacy. We asked them how effective their calls were on a scale of 1 to 7, where 7 is very effective. And here you can see only 15% of our surgeons found that those virtual sales calls were effective or very effective. So in follow-up discussions, again, with these surgeon stakeholders, they really pointed out that if we're taking the time to meet with them live, whatever the platform, we really need to be targeted in our communication with them, and they're expecting new news. So they're expecting to hear about new products or indications, new clinical data, or information related to their products in a COVID time. So how do they change perhaps how they utilize use of those products due to COVID-19? So these were some of the things that they were expecting from their medical device reps. But still, they were really welcoming communication and really wanting to maintain that connectivity. The last thing we wanted to share with you here is some information on conferences. You can see that 71% of our surgeons and anesthesiologists were planning to attend an in-person conference in 2020. Now, though, just about a third of them said they would still attend in person if it were to go ahead as planned, and about a third said they would be open to a virtual option if it was available. But nearly half of our surgeons are saying that they're concerned about staying up to date on products and therapies given the disruption in these medical conferences, and 3/4 of them are planning to seek additional information from their med journals to stay up to date, which again brings forward another opportunity for medical device companies to really get creative in how they're communicating and staying connected with their clients going forward, because they are hungry for that information and they are concerned. And so it's another way to make sure that we are partnering with them. So that brings us to the end of the surgeon data today, and there's just a few considerations I wanted to leave you thinking about. Some of the things as you move forward that are going to be important to understand are what differences can be found at the specialty level or by site of care, by geography, as far as how these procedure volumes might rebound. Will our surgeons increase their acceptance of telemedicine, or will they really abandon its use once the threat subsides? And will patients have a role to play in determining how this plays out? And how should our companies effectively be communicating with surgeons to help them bridge the information gap? So we're really excited to be working on some Wave 2 data that will help to answer some of these questions and partnering with you. And now I'm going to turn it over to Meg Gavigan, who's going to give a quick glimpse of our Phase 2 offering for hospital administrators and payers.
Great, thanks very much, Jenna. Yeah, we'll round out the stakeholders for the medical device and diagnostic ecosystem with the hospital administrators and payers. So Here we conducted qualitative, in-depth interviews with our hospital administrators and payers, and we did this in follow-up to the findings from the lab research and surgeon research that Dan and Jana just presented, so that we could really find out from the non-clinical stakeholders' perspective what the short-term and long-term impacts will be from COVID-19. So you can see here the mix of administrators and payers that we spoke to, really trying to get a comprehensive look across these different stakeholders. So I'll start first with the hospital administrators, and I'd like to focus on 3 key impacts from COVID-19 from their perspective. Not surprisingly, given what you heard from Dan and Jana, financial impacts in the short and long term were top of mind for our hospital administrators, and I'll talk a little bit about that in a moment. We got some perspective on how hospitals are looking to resume elective procedures and how that might vary by geographic location or the experience of COVID-19. And then finally, while this has been an extremely busy time for our hospital administrators, they do still see avenues for seeking input from their manufacturer partners and are going to be looking to you increasingly in this period of resumption of elective procedures. So let's start first with the financial impacts. Short term, Jana mentioned this, it was echoed by the hospital administrators. The reduction in elective procedures in mid-March to the end of April was really a huge impact for hospitals. And this is really their source of revenue, source of cash flow. So you can see in some of the other short-term impacts that the downstream results of that reduction in cash flow. So our hospital administrators did report furloughs, pay reduction, and hiring freezes. Most reported that that would be an issue in the short term. They did see in the long term that that would not be an issue, except in our rural hospitals or smaller hospitals. Those hospitals are more likely to have contract workers who may seek employment elsewhere if they're furloughed or have a pay reduction in those smaller rural hospitals. And as has been stated by both Dan and Jana, capital expenditures have been halted in the short term. As we did ask our hospital administrators to think towards the future, what are some of the longer term impacts? The financial health of the hospitals has been stabilized by some of the funding that's available through the CARES Act, which is still being distributed by HHS. But there is a concern that even with that stabilization, there may be longer term financial impacts, particularly for those rural and smaller hospitals who may see a change in their case mix. While the capital expenditures have been halted currently, that doesn't necessarily mean that hospitals are going to just come back to their planned expenditures for 2020 when their cash flow improves. Our hospital administrators did report a reprioritization of any planned spending and more increased scrutiny. And hospital administrators did speak a bit about their priorities for contracting in the future. A lot of them reported that they've tried to move more towards cash purchases with some of their capital expenditures, but they do see a swing back towards leasing and renegotiating some of their current contracts due to the financial health of their organization. So we talked about the deferred procedures with our hospital administrators. Many of the administrators we spoke to, their hospitals have already started to resume elective procedures. And so certainly there's the backlog of those operations that were halted or rescheduled due to the pandemic, but they also noted that they're concerned about the future of the surgical procedure volume due to the fact that many of the surgical procedures have limited assessment capabilities through telehealth appointments. Jenna spoke to this a little bit, that there's only so much that the telemedicine assessments can do to really refer someone for a surgical procedure. So there may be even a future case surge once people are able to go back to their primary care physicians and other specialists. So in terms of what specialty was impacted, cardiovascular and orthopedics were cited most frequently, though neuroplastic surgery and general surgery were also substantially impacted by the deferral of procedures. So when we talk to them about how they plan to address this backlog, I would say first and foremost, our hospital administrator said the patients, the need of the patients, patient severity of disease was certainly a high priority in terms of what they would look at in prioritizing procedures. But it was also of mind for the hospital administrators to consider the revenue of the procedures or the margins of the procedure to try and balance the needs of the patient with the financial health of the organization. And they may be willing to extend hours to address that backlog, but they're really concerned about their staff and the capacity of their staff. Even though surgical procedures were not occurring, their staff may have been reassigned to care for COVID patients. So they want to be mindful of the surgical staff's capacity. And while they feel their inventory levels are high to address the deferred procedures that they have right now, they are looking to their manufacturer partners to help with supplies for expedited orders or for things that have a shorter shelf life. So I talked a little bit about this engagement that the hospital administrators are looking for from their manufacturer partners. You know, it goes without saying this has been a very difficult time for the hospital administrators. They've had significant disruption in their responsibilities. Many of them reported having to furlough their own staff. So it is a good time to be kind and patient with our hospital customers. They do see having evolving needs as they try and address the backlog of procedures, and will be looking to their manufacturer partners to help them address some of their evolving needs. I mentioned at the outset that they would be reaching out to their manufacturer partners, potentially for renegotiation of those contracts that are already in place, trying to identify opportunities for more favorable financing terms, both on current contracts and also in the future. And as Jenna already referred to, there are limitations in the ways in which manufacturers can be on site right now. Hospital administrators do echo the fact that they do see a return to normal over time. So to round out our findings from the hospital administrators, I think the really important part from a manufacturer's perspective is thinking about the way you plan your interactions with these hospitals. Business planning is really going to need to be tailored. The experience of COVID-19 has been very different by geographic location, both in the time in which procedures were halted, as well as the patient volume at peak and currently. So those will need to be taken into consideration. And then also the facility size and financial health of the organization. Hospital administrators reported by and large that the financial health going into COVID-19 is going to have a significant impact on the way in which they're going to be able to rebound in the short term. So I'll move also to talk a little bit about the US payer perspective. You know, if you think about the payers, they are seeing probably the least impact, or they report seeing the least impact today. But we'll talk about some of the ways in which they see their perspective or their business changing in the short term. So policy decision making appears to be occurring in its normal fashion, albeit virtually. But they have taken note of the high impact of high unemployment and reduced healthcare utilization, and have started to think about what that means for benefit design moving forward. While there has been some temporary relaxation of policies to try and help their provider networks deal with the impact of COVID-19, not all of those are going to be permanent. So for the payers that we spoke to, business as usual, as best you can in a virtual environment, is occurring with regards to their P&T committee meetings, the medical policy meetings. Those are continuing to occur, albeit remotely. They haven't had any reason to alter their approach to coverage decision making. So they're still considering the same factors when they establish their medical policy, and they are still open to engagement from manufacturers. So this does provide an opportunity for manufacturers to be part of that conversation in the medical policy creation. We talked a little bit about the potential impact to the benefit generosity in the future. You know, the two combined issues of the potential membership decline that they're going to see from unemployment, combined with the pressure that they're feeling from their provider networks to increase reimbursement rates given the reduction in healthcare utilization. Both of those factors really are going to impact the way they think about their benefit generosity moving into 2021 and may mean less covered services or an increase in patient cost sharing. And then finally, the relaxation of policies. You know, payers are trying to do the best they can to help their physicians in this time and ensure that their patients receive care. So we've seen things like the reimbursement of telemedicine services that are being reimbursed at the same as in-person services, or issuing full reimbursement for services that are only partially provided. So those are some opportunities that payers have taken to try and minimize the physician's burden at this time, but they don't anticipate necessarily that that will take place or become a permanent case. So here I think the business implication for payers, you know, they have managed to maintain business continuity in this very disruptive time, but they do see a time in the future for an impact to their benefit design as a result of the reduction in covered lives and reduced healthcare utilization. It's a nice opportunity at this time for manufacturers to shape perceptions of telemedicine and digital health. I mentioned the fact that payers do report that they see their policies returning to pre-COVID medical policy. But this presents an opportunity for manufacturers in the telemedicine and digital health space to prove the value that they can bring to future medical policy decision making. So I'll wrap things up and turn things back over to Jessica so we can take some of your questions.
Okay, excellent. Thank you, team, for that fantastic content. We're now going to open up for discussion and address the questions that we've received, but just a reminder, you can use the questions function in the control panel to continue to submit questions. The first question is, what are the key factors from your research that can help to predict future surgical procedures?
I can take that one. This is Jana. I think that one of the key indicators that we noted within the research is just how much depth needs to be considered in terms of understanding how these procedures will come back. We saw when digging through the data a very different experience, for instance, by institution type, where academic centers had a very different experience than a community hospital may have. Of course, geography definitely comes into play here. Hotspots versus not, urban versus rural. That's going to be something to consider as well. Site of care, we saw surgical centers really shut down due to the bulk of their procedures being elective, but they also feel like they're in a place to come back more quickly because they haven't had to convert as much of their space, and so they're sitting more ready to go as they ramp back. And finally, specialty. Every specialty that we talked to had a slightly different experience here and a different layer to their practice as to how much of their work was still going through and how much of a backlog they have to work through. So I think really digging in and understanding the nuance and how that pertains to your business is one of the key things that I think our work in wave one and coming in wave two is really going to help to uncover.
Excellent. Thank you, Jana. The next question is, you mentioned it will be important to continue monitoring the COVID testing market. How do you expect the COVID market to evolve, and what aspects are most important to monitor as we move forward?
Yeah, it's difficult to tell exactly how the market's going to evolve, and one of the key things to keep an eye on here is what sort of changes and things that have been implemented so far are transient versus what is going to be more permanent and long-lasting in this landscape. But at this point in time, I'd say it's give careful consideration to the monitoring of how the different value drivers change for adoption of platforms and different tests, as well as understanding the different testing scenarios. Right now, there's a ton of different patient testing scenarios that are being considered for pre-symptomatic patients, symptomatic patients, pretty much any sort of procedure where there could be an aerosolizing event, as well as being careful of watching how some of the testing patterns might change in the landscape here, especially as these healthcare systems and provider organizations start to reopen, and there's more near patient testing in outpatient facilities and urgent cares and physician offices as those reopen as well. The on-the-ground situation for labs really does seem to be changing from week to week from what we're hearing, what we heard on the callbacks. And if and when the pace of change slows down, it may be an easier time to glean a more accurate projection of future demand for COVID testing overall.
Okay, thank you. Our next question is, did you learn anything about new innovative device adoption as the country settles to a new normal?
Sure, I can give some insight into that. So we talked a little bit about the capital equipment, the cessation of capital equipment purchases, and beyond that, I think it's important to keep in mind that the financial resources of all hospitals are going to be more closely scrutinized. So while there's certainly an openness to consider innovative solutions, particularly those that might be able to address, quicker throughput or quicker procedure time, things like that. There's still just the issue of the financial health of the organization and the ability to purchase at this time. The other thing that the hospital administrators brought up is just the fact that it's a difficult time to trial new medical devices in the hospital setting. Right now, hospital medical device representatives aren't able to be in the hospital routinely. And also the time of the surgeons is really being completely taken up with trying to address backlog. That doesn't leave a lot of time in their day for trialing of new equipment or time to consider new approaches right now.
Okay. The next question is, can you expand on the implications for the future of in-person medical device rep sales calls?
Yes, I'll take that one. This is Jana. We had a lot of good information and discussion with these surgeons as it relates to medical device reps. I think, one of the themes we discussed in the presentation is how our surgeon groups, more than others, are really looking to kind of get back to normal, and that really carried through when talking about their device reps, generally speaking. So, we saw that a lot of med device reps were still getting in to do those clinical assist within procedures in the OR, and they expect those types of volumes to go largely back to normal once the immediate COVID threat has passed. And they generally expect to be letting reps back into the facilities altogether. But in the meantime, I would say, they really made it clear that they have this desire to stay connected, to maintain communication with their device reps, and they're really looking for them to be working for them behind the scenes too at this time. So we had some conversations where they were saying they're hoping that their device reps are working with their purchasing department and their administration to make sure that when they're able to get back into the OR, they have the product that they need and that the product is good and not past expiration dates and it's ready to go, so they can hit the ground running, that they're helping to keep them up to date on what's going on in the broader space as they get distracted in terms of really trying to push all their efforts into getting through this backlog. They're going to really depend on their device reps in that manner as well. So I think longer term, their expectation is that things will return largely to how they were pre-COVID, but in the interim, there's still a lot of opportunities to be engaging with these surgeons.
Okay, very good. The next question is, from the hospital administrator's perspective, how does 2021 look for spending?
Yeah. But the 2021, I think, is going to be an interesting year, I would say, for most of our hospitals. I talked about the fact that our administrators report that they're not just going to move their planned spending from 2020 and just move it forward to 2021, and all of the planned contracts are just going to go forward just in a delayed fashion. They really are going to reprioritize. Certainly any capital equipment spending that they would expect for 2021. So while their financial health will likely improve and allow them some additional capacity for purchasing in 2021, that doesn't necessarily mean that because you've already been in the midst of negotiations in 2020 that will materialize in 2021. And then the other thing I would just say is just hearkening back to the geography. I think that the experience of COVID-19 has been very different across the United States. And so what's true in New York City is not going to be true in Omaha, Nebraska, or in some of our rural hospitals. So that's, I think that the hospital administrators certainly have that balance of trying to balance their experience of COVID-19 with when they've been able to ramp back up with their elective procedures as they think about their budget planning for 2021.
Okay, I'm going to sneak in one last question. From the slide that said the overall impact of COVID on lab operations is extensive and troubling, do you feel this is long-term? And follow up any input into how long?
Yeah, based on the first wave of findings, I'd say there's likely going to be a material impact at least through the beginning of next year. Instrumentation and platform sales are likely to be more impacted than testing and reagent sales. Labs will, of course, need to have the necessary consumables available to perform testing as patients return to the healthcare system, but it seems like that appetite for new equipment and platform upgrades might not be there. So I'd say it's really important overall, as Jana and Meg have emphasized, to continue to monitor the situation overall in the U.S. healthcare system and to monitor the outlook and observe whether lab sentiment improves here. It's really going to be important to keep a close eye and stay in touch with these market realities so you can set realistic expectations for purchasing of your equipment and consumables. And it's also highly likely that there's probably going to be some sort of institutional and geographical disparities in terms of pace of recovery and the resulting long-term impact here.
Great. Excellent. Okay, well, thank you. In the spirit of ending on time, we're going to conclude today's session. So I'd like to thank all of our attendees again for sharing part of your day with us. We certainly hope you found the session to be valuable to your understanding of these issues and, of course, planning your related initiatives. And as mentioned, you will receive a recording of this webinar directly from our team in follow-up. We also encourage you to see the handout section for a download of our global MedTech capabilities here at Ipsos. And of course, we welcome the opportunity to personally speak with you. So you could reach out to any of our speakers listed here or certainly your local Ipsos MedTech contact. And with that, I'd like to thank you once again and wish you a wonderful rest of your day. Thank you. Bye-bye.